That's all of you. At some point, you will be a trauma radiographer unless you go work at a clinic somewhere. You do have to be knowledgeable of those vital signs that we learned back in patient care. So knowing whenever the blood pressure is spiking, when the breathing rate is changing, pulse rate changing, all those red flags. I mean, luckily, they're going to be usually hooked up to a bunch of monitors, and they're going to be screaming at you if something's going on. But just in case, that's something you want to be aware of and be looking at as well, because you got to report that immediately, especially if they leave you in that room all by yourself. Know the ranges. Be competent in CPR. At any moment, they might point to you, Monsi, jump in, your turn. And you can't do that whole, I've never done that before. If you're in a hospital, you're CPR certified, and you can actually get written up for that, by the way. You gotta be able to jump in there. Now, if they see you doing a sloppy job, they don't say get out the way. But you still gotta get in there and relieve somebody, because CPR is a very tough, physical, laborious task. The mannequins that you practice on, very easy. A real person's chest, you gotta put some muscle into it, and you gotta push hard. You gotta break ribs. Yes, you do have to break ribs. If you're not breaking ribs, you're not doing it correctly. It wears you out really fast, and you gotta be constantly switching out. Is that ice cream?
Yep, him and that ice cream and that coffee.
Okay then.
That
And
might
of course,
look
be
like-
familiar
Hey, it looks like you've
with
been
the
getting good.
location, contents of those crash carts. They might say, Shaheen, go to the crash cart and get me a oxygen tube. You gotta know where that's at. You can't be like, oh, I've never seen that before. What's an oxygen tube? I'm just a lowly x-ray tech. I don't know this stuff.
What are you hoping?
Well, if you say that, and I have seen people do that, what do you think they're gonna do? Well, not only are they gonna be angry at you, but what do you think they're gonna do after everything subsides?
Write you
They'll
up.
write you up, write the whole department up, because why'd y'all send this incompetent tech over here that doesn't even know what an oxygen tube is? You gotta be familiar with the stuff, familiar with the terminology, be able to respond accordingly if they point to you and say, go get me something. You can't go, oh, I've never seen that before. What is that? It's not gonna fly. You gotta know. You gotta know. So obviously, guys, best practice is speed, accuracy, quality. We balance all three. That should be every exam we ever do. But we still apply that to the trauma radiography. But once again, it's a very high stakes, high stress, loud, crazy, chaotic area. You gotta tune all that out, get in there, do your job, get out the way. Speed, accuracy, quality. Positioning, you gotta be creative with that positioning. Standard precautions, make sure you wear gloves, mask, eye shields, gown when appropriate, especially if there's fluids flying all over the place. And sometimes fluids are flying all over the place, especially if they've nicked an artery or something, squirting blood out in the air. That does happen. You ever seen that? That's not just in cartoons, that really does happen. If you nick an artery, it'll shoot out like a cannon sometimes.
Arterial
You can be in,
spray.
you can be in the
you know.
splash zone.
I saw shit right after.
So wear the appropriate protective measures. Clean your IR, put your IR in a bag preferably, like a nice bag so it doesn't get messed up. Hand hygiene, obviously, do everything you can do to protect yourself from those dangerous fluids. Mobilization, like we already said, never remove immobilization without physician's orders, and even if a physician orders you, I just make them do it. Better safe than sorry. I'm not gonna have that on my conscience if I mess it up. Make them take the devices off. That's just less risky anyway. Some injuries require follow-up procedures. Knowing what to do increases appreciation for your role in the ED. What do you think that's referring to? That's actually a very great tip for you guys. Anticipation and knowing follow-up procedures. What would that be? What would be an example of that, in your opinion? Anyone name me an example? Yes.
They're gonna take you to CT over and like.
Well, not exactly. Let's just talk about your role as a radiographer. Purely your role as a radiographer in the trauma room.
Is it like if there's like a person that is in a car accident and then you take the picture before and then you know that they're gonna do a surgery or something, or they're gonna do some intervention and then you're gonna take another picture after?
You're on the right track. So let's say, you know, they came in with, like per their report, massive car wreck, there's pain from the C-spine down to the L-spine, but they just ordered a lateral C-spine. But you as a radiographer know that patient needs T and L as well. So while you're there, you say, hey, I know you ordered the C-spine. While I'm here, do you want me to go get the T and L because I noticed that the patient has pain going all down the entire spine? They'll often be like, oh yeah, you're right, we forgot about that. You're taking that initiative because you know that they need more than what they initially ordered. So you're anticipating, that avoids follow-up later, and you're getting it all done on the spot and helping that patient with their overall diagnosis.
So to call the radiologist and ask them to order. some other
Correct,
one. Okay.
correct. Well, the trauma room people can put it in for you typically, not just the radiologist.
Okay.
Just, we have them put the order in for you.
So yesterday we went to the shock room and like they, I mean, that patient was like, he was, I mean, not he, but she, was all really bad in a terrible state. And, so they just said, oh, just take the chest x-ray right now. And I know there was like tenderness in the shoulder, there was knee
Mhm.
problems and everything. And then after that, they said, okay, they're gonna go to CT. And then, so it's like, what's the point, like, we take one x-ray, they go to CT, and then they, ordered more x-rays afterwards.
Because most of those people ordering that stuff are incompetent and don't know what they're doing. To be completely honest.
And then we
That's,
come back
that's
to
what we
take more
call,
x-rays? I
that's
don't
one of the,
understand.
that's something I wanted to actually do an entire thesis on, back when I was doing my master's degree, but I didn't have enough articles to use, was image redundancy amongst trauma doctors and even radiologists to an extent. The fact that they would just order stuff like that when it wasn't even needed, and,
So I thought
It's
CT
just-
would take care of it, why did
it
why did
does.
you have to
It
take
does.
more
So-
x-rays?
since they had the CT, technically all that other stuff should have been irrelevant at that point. They don't need the other plain films after that. Now, if they did the plain films first and saw CT was needed to further analyze, even though it's more exposure, that would make more sense. But to go from one X-ray to CT back to regular X-rays, completely incompetent.
Would you say no then? Or,
Well, you're not the CT tech. I
but
mean,
it's like, what's it called? Common sense.
do you say no to, wait, say your statement again? What were you
Like,
saying?
it's like what she said,
That's how
they
they
said that,
drinks.
they asked for the CT
Starbucks.
first, or something like that, and then the
No, they
X-ray.
took the chest x-ray first,
Do they
and
have
then they
any?
went to CT, and
Do
then
they
when
have
they came
any?
back, we had to take
It's been
shoulder,
affected.
femur, and knee.
Would they like to get?
Oh.
Unfortunately,
What?
it's
Would
out
they
of your
like to
pay
school?
grade
Oh.
at that
Why
point,
just
but
take it out for like 5 minutes? Is it out?
from an ethics standpoint, that should not have been done.
Residents do
Like,
that
it
all
was
the time.
easy
It was
enough.
on the
They
whole
do.
body.
Straight out.
They do.
It is,
Need to do it this
They do, or like, there'll be like a wrist injury, and they'll order
Right.
finger, hand, wrist, forearm, elbow,
And you like,
humerus, and you're like,
why?
what are you doing? What?
Why do you even need that?
And you ask them, is your arm hurting? No. Is your elbow hurting? No. Is your forearm hurting? No. Is your finger hurting? No. Where are you hurting? Just my wrist.
And then on your whole.
Now, in that case, I always would call and say, hey, I just wanna confirm what you ordered here. I'd be very tactful. I wanna confirm what you ordered. Patient saying they only have wrist pain. The wrist x-ray will localize that injury. Are you sure you want the rest? That's kind of manipulative how I said that, but you see how I did that?
Yeah.
The wrist x-ray will take care of that localized pain. Are you sure you want the other x-rays? Oh, I'm sorry, I thought we needed the other ones to see the wrist too. They'll say stuff like that. Yeah, you can delete the others and just do the wrists. That's being a patient advocate, by the way. It's okay to question exams. You should. Once again, like I said, there's money attached to each of those procedures as well. You're saving them a lot of money by bringing it down to just one exam. Jay, question?
I experienced something like that the other day, in which they were asked, they had pain in their finger, and they asked for the whole arm, including like the shoulder. But whenever I asked the tech why was that, they said that they had osteomyelitis, and that the doctor did that intentionally to see like, I guess some form of infection happened, or.
That would make a little
incident.
more sense in
But
that
they wanted to
case.
see if it traveled all the way up.
That would make a little more sense, but in general, it's just very unfortunate that they do that. But don't be afraid to speak up. Try to help your patients out. So best practices, guys, of course, whoa, this fell over.
Oh, blood pressure going down, you alright?
Goodness.
Orthostatic
CPR,
hypertension.
Got lightheaded for a second there.
Orthostatic
Sorry.
hypertension.
I'm good, I'm good, I'm good.
Let me break your ribs.
I'm okay. Attention to detail, ED protocol, scope of practice, and of course, professionalism at all times. And that's what we base all those code of ethics and practice standards that you learned way back in that first semester as well. Okay, so review questions, yes.
I was with the tech doing verticals, and we did, I think, they ordered like pelvis, femur, tib fib, and all that stuff. And then I think we had got the pelvis, so they copy and pasted for the hip, for right here, and then we just took the distal.
Interesting.
And it's like, I'm not about to expose them again. And I was like,
That's good.
okay.
That's smart. Very good, very good. Okay, so review question. It is acceptable in trauma rad to lower image evaluation criteria because patients generally cannot cooperate with standard positioning protocols. True or false?
True.
True. I hope that's not true.
So is it that because really they cannot move and
Who's
we,
this face
we
from?
take it in the, we're not supposed to move them too much in the trauma.
I'm gonna rephrase this. Is it ever in our career acceptable to lower standards at any point?
Not lower standard. the
Never.
But
Only your
change
own.
positions, like. you
Standards,
do.
that's what criteria is. Criteria is the standard by which we deliver quality images. Is it ever acceptable to deliver anything less than perfect? I mean, obviously everything can't be perfect, but should we always strive to try to get something perfect? Yes, we always deliver the top quality images, period. Does not matter if they come in and they're just a floating head in a jar and they order 10 limb x-rays and the patient has no limbs. We're still gonna strive to get the best image possible based on what they ordered us, no matter what, no matter what. Okay, immobilization devices can be removed only by physician's order, even if the devices will cause artifacts in images.
This is true.
Correct. Even though, once again, I do advise to you, make them do it. It's just safer that way. I've never felt comfortable removing that stuff personally, but technically, per law, once you have the order from the doctor, you're allowed to do so. But document that they told you, so it doesn't fall back on you. Okay, patient prep, trauma obviously causes much anxiety. Explain what you're removing and why. If there's artifacts, in general, in the trauma room, you're not really going to do much removing. I would say, really the only time you would at least require removal of clothing is if it's going to completely compromise your image. For example, they have a pelvis x-ray in the trauma room and they have jeans on. And you know those buttons, those snaps, those zippers are going to be right in the field of view. The jeans are going to show up really bad, but they're freaking out and they want that image. So what would you do? You would say, in order to give you a diagnostic image, I need you to remove the jeans. You're telling them to do it. They'll cut them off, they'll remove them, they'll do whatever they gotta do to get those out of the way because it's gonna compromise your image quality. Don't try to take it with the jeans on unless it's just like impossible to get that off, or the patient's like coding and dying or something. But try to get them to remove that stuff and get it out of the way for you. Okay, your IR collimated field sizes for all trauma procedures will be the exact same as for routine. Always use smallest IR to demonstrate your anatomy, collimate down to the area of interest. Don't, what's the word they like to tell y'all?
Leave it open?
Don't leave it open. Don't leave it open. Close it down. Close it down. It does make a difference. By the way, ice pick.
What?
They're still alive.
Ice pick?
Mhm.
What's that
One of
little
those.
piece in there?
This?
Yeah.
It's a tube.
Oh.
Poor baby.
It's an NG tube. This patient survived. By the way, if you're ever impaled by something, do you
Don't
pull it,
take
do you
it
pull it out?
Mm-mm.
You do not. You leave that in there until you get to the hospital, let them take care of it. Don't
What is
ever
the
pull.
ice pick?
Hmm?
What is the ice pick?
So it's like it's a spike that you can take to break ice apart.
The one for at home or is it?
You can have it at home.
Or for your own drinking stuff?
Mm-hmm.
Did they stab the baby with it?
I
Or was it accident?
don't know the full story on that, but
Looks like it.
I don't know how else. The baby's not gonna fall on it, or at least I hope not. That looks like a stabbing.
Yeah.
It's got down.
Okay, SID, standardized as part of a procedure protocol. When SID is not specified under a projection, per your Merrill's textbook, which the registry does reference, you're always gonna go with 40 inches. If your textbook does not tell you a direct SID, you always assume for 42. 60 to 72 is gonna be your recommended whenever you have increased OID. So if you have a part that cannot be laid flat on a cassette in the trauma room or whatever, say their hand just can't come in contact or foot's floating in the air like that crazy picture I showed you, they recommend you increase 60 to 72 SID, because as you increase SID, what happens to the OID and the magnification?
It decreases.
It decreases. That's the best way to mitigate magnification. Absolutely right. By the way, do we ever use digital markers?
No.
Well, what if it's a trauma room and the blood's squirting everywhere and their guts are on the floor and there's a severed arm over there and
Put your marker in there and
you just stick your marker in there and get nice and juicy with all that blood and guts on it. That's right. Now, obviously in real life, will be more flexible on that. But if they ask you on your registry, and I keep telling you that because they'll give you a scenario just like that. They'll get a real crazy question. Patient A comes into the trauma room. Nurses are going around like chickens with their heads cut off. Doctors are shouting at you. Patient's arms on the floor. Intestines are coming out of the stomach. You got to get that image done in 5 seconds. Are you allowed to use a digital marker at that point?
No.
You still must use physical markers per the curriculum. That's a bit of an exaggeration on my part, but you get my idea. I'll give you a really fancy answer, but you still use physical markers. Obviously, closed collimation, optimum technique. Still use your shields. By the way, this is an example of an ovarian shield. They don't have these very often.
Looks
Some
like a heart.
facilities have them. Very difficult to use. They often are shaped like hearts, especially in pediatrics. Very difficult to use. So remember I told y'all with females, a lot of your abdominal and pelvic x-rays are optional shielding. They're optional shielding unless you opt to use an ovarian shield, but this is very difficult because you're kind of shooting blind, because technically this is done incorrectly. Why is this done incorrectly?
It's covering the
They're not
anatomy.
centered or.
It's covering part of the pelvic brim right here. What if there was a fracture or pathology there? I just compromised the exam. You gotta get that directly in the center, otherwise you have to repeat that x-ray. If you have to repeat the x-ray, that defeats the purpose of protection. If that makes sense. So it's usually just safer in general just to leave the
Not
shield
use
off
it.
on females, shield males because the gonads hang lower on males, and you can still do that without compromising your image.
So according to the curriculum, if that question is asked, we'll say for females.
Females are optional, males are mandatory. Yes.
It's kind of wacky, Yasmin.
What's that? Once again, immobilization devices are not to be removed unless ordered by the physician. Imaging procedures are often performed without removal. More times than not, obviously, if they're on a backboard, if they have straps, if they have a C-collar, you're just gonna leave that on, shoot through it, because it's better to do so without causing further injury. And usually they're not cleared until they go to CT anyway, and most often you'll be there prior to CT, get those trauma images before they just go ahead and opt for the CT and check things out from there. Documentation, that's a big one, guys. Documentation, I know we get busy, it gets very hectic in that trauma room. I would say more so than any other area, document everything you do in the trauma room, because they will try to blame everything on x-ray. If there's a stinking chest tube missing from their tray, their crash cart, they're gonna blame it on x-ray. Why? Because x-ray is easy to blame, and people in x-ray don't like to stand up for themselves. I hope your generation changes that, by the way.
Have you been
You
to
should.
class?
Be very vocal and stand up for yourself. Best thing you can do to protect yourself, though, is document everything going on. When they ask you to do something, make note of it. If they ask you to hold the patient down, like hold the arm still, document that they told you to do so. Dr. Doolally told me to do this. Cover your tracks so nothing comes back and bites you in the rear end should there be some kind of complication or someone gets mad, so on and so forth. It pays to document, yes.
So when you ask a doctor, for example, I saw the MRI, a patient had like a filter or something, and they called the doctor, and the doctor said, yeah, go ahead, still do the MRI. And they said, oh, I'll just call it just to cover my butt. But like, what if you later, cause something comes up and you're like, the doctor said it, but the doctor's like, I never said it. You don't have like any written proof or?
Your
Is that-
documentation is suffice.
You put
Your
it in
documentation
the-
suffices if you put it in the order, like you put in Epic,
Is that phone call being
Doesn't matter
recorded
what
or
he
anything?
says.
Nothing?
So
doesn't matter what he says.
it's not
That's
his
your-
word
that's
against
your-
ours.
That's your cover, is writing it down. Yeah,
What if he then documents the opposite?
it's a he said, she said. It's not gonna go anywhere.
So yeah, okay. It's never.
Now, if
his
he
word.
documents it and you didn't document, well, then you're kind of out of luck there. Because he has a defense, you have nothing. But you can cancel, basically you can cancel each other out
Okay.
via he said, she said.
So it'd be like per doctor, whatever,
Mhm.
they said that it's okay to do it.
And I'm telling you guys, write everything down. Seriously, document everything, because that one time you don't, it's gonna come back and someone's gonna complain and you won't have that defense. So, and those nurses, you know, I complain about them a lot, they just love to blame radiology. They love it, because they don't like us, well, I don't like them either. So, be them at their own game, document everything you do. Trust me on that. Image eval, same as your routine, obviously optimal quality. It does not matter what the situation is, we still always strive for optimal quality at all times. in all types of examinations. It's a poor practice to accept lower quality images. Some techs embrace that a little too much, and if they are very accepting of low quality, you're better than that. I've trained y'all better than that. Always go for the best. Try to do the best for your patients and for your career. It really does pay off. Trust me on that. Okay. What time is it, guys?
2:59.
That is where I want to stop today because my voice is about to. get
Yeah,
out
you said you was
here.
kinda dizzy. I think
Yeah,
you
you
just
said-
said we got
My,
some
my
candy.
voice is getting really tired. That's why I need this Christmas
Have you
break.
ate?
I have ate.
What
So
about water?
what I will do, guys, the rest of this
Uh-huh.
PowerPoint is literally positions you've all done before, like lateral C spines, mobile chest X-rays, so on